È un simposio bellissimo, organizzato molto bene, si differenzia, tantissimi invitati, relatori di calibro, cioè di una certa importanza, e soprattutto novità, cioè flebologia è un evento praticamente che se non si aggiorna, cioè non ha senso, cioè, e qui veramente le novità ci sono state.
Molto ben fatto, al di fuori di alcuni canoni che regolano altri congressi societari o universitari, uscendo da questi canoni un risultato eccezionale dal punto di vista della qualità delle informazioni ricevute.
We can see all of their knowledge from other countries, from UK, from Italy, from lots of other places from Europe. So I think it's the most interesting and opportunistic way for me to see their expertise.
È un simposio internazionale, un simposio che unisce tanti professionisti e anche da loro c'erano. È un simposio che lega le varie metodiche di trattamento e di primo impatto piacevole assolutamente.
I am very happy to be here for the first thing, and I admire the team that organized it, because it's a lot of people here, good questions, very good topics, and I think if you repeat it every year you will have a good luck. I would of course recommend this, because Venice is a very good location for lots of next nearby countries. I think it's great to do it in English, because this allows people to come.
What is very important, there is no nerve damage that can occur with thermal ablation, no burns after the procedure. Now about something about Venacil, which is an implant, in fact, in the strict sense, because it is not biodegradable and remains in the patient for life. In both cases, arterialization and recanalization of the ablated perforators were observed, and I've got the same in my private observation. And we can say about we have a significant risk of DVT and pulmonary embolism. And now something about sclerotherapy. Despite interior technical outcomes, the clinical outcomes of the foam therapy do not differ from EVTA, especially after 1 year, which makes ultrasound guided foam sclerotherapy still an attractive method, especially considering the cost effectiveness of the therapy. There are some side effects related to this procedure. You can see, but the most important are pulmonary embolus, arterial injection, from time to time skin ulceration or necrosis. And the closure rate is not too high like in the other procedures. And the result of current techniques are good, but we still have to remember that we have to use anesthesia, and risk of paresthesia and nerve damage, and we need to wear compression stockings. Using thermal techniques, and but according to the directions, we have to remember about that there is still not very precise directions. What should be closed or what should be ablated. And we have to remember about the complications, neuropraxia, paresthesia, DVT, and I still think in my private practice, still see about that not only the diameter 3.5 millimeter is a direction for me for closing or leaving this perforator. And the most important for me is the reflux. And there is something like mass effect. What does it mean for me? Mass effect of the insufficiency of the perforators. That is what I used to call that we have many small perforators which are sufficient, but in mass we can see oedema, and this is another thing what should be take undercover about in a few freer scientific researches. And now there is a question: is the NTNT ablation a gold standard? In my opinion, for sure not, because there is a lack of precise guidelines, lack of large trials, and we observe recurrence of the insufficiency, arterialization of the glue-ablated perforators, risk of DVT and pulmonary embolism, poor effect of sclerotherapy. And because we are dealing with a dynamic working structure and post-inflammatory changes disappeared over the time, and we have to remember about this. And so in conclusion, non-thermal and non-tumescent ablation is in fact difficult topic. Methods of administration of both glue and sclerosant require experience and proficiency in Doppler ultrasound. Thermal techniques are definitely more effective, safer, and more precise. So far, ultrasound-guided foam sclerotherapy and CAC have been shown to be at least equivalent to the endothermal techniques. And for sure superior to ultrasound-guided foam sclerotherapy with respect to occlusion rates. And they also appear to offer better comfort and aerial return to normal activities. And I believe that the further randomized controlled trials with longer follow-up, will be able to provide more robust evidence of their respective merits. And for sure, this is a very important topic, and in my opinion, very difficult.
Okay, thank you so much, Jan, for your comprehensive presentation. A lot of thoughts for toe, especially you touched the point when you said when to treat these patients, and now, and then only then the question will be how. Anyway, in Venice, we will have a lot of things to say about that, and thank you so much for joining us today. And now we move to the next topic, session number 6. And please, director, just change the slide. Oh. Yeah, number 5. I don't see the slide.
I think this is my time.
Yeah, it's your time, Prof. Yeah, let's go with that. I would just want to introduce your session.
Great, keep going.
Yeah, the recurrency is a topic for us, and the key points, of course, we do know how to classificate the recurrency, but sometimes we should know better and understand better when to treat this recurrency. And of course, how? foam. It's something that we say every day, but maybe we can think about also in the Chiva concept in this type of treatment. Surgery, yes or not, is still an option. Glue, technical notes with glue with direct puncture, and can HIFU be the answer to this topic? A lot of things to say, but I want to introduce next speaker. It's a great honor and pleasure to have with us Professor Victor Canata. Thank you so much also for the patronage of the Vein and Lymphatic University, a great community. I'm really happy to be part of that. And I thank you also for your availability, such as all the speakers of today. Thank you so much. We had some technical problems, but we are nice guys and we move forward. So thank you so much. It's your time, Prof. Thank you.
Okay, I will start sharing my presentation. Thank you very much, Luca. I just would like to remember to everybody else that the meeting in Venice will be already a great meeting. We will look forward for this. We will just to have everybody else together, and we will just discuss about some good stuff regarding about laser. That is something else that we really like it, love it, enjoy it. Porcupine technique is a new kind of technique that usually start working together with the laser. When we start doing laser, we think that a lot of years ago that in 1999 with Dr. Calvin, all the teams start doing laser has changed the way that we treat the reflux in USA and also in all the countries. The number of ligation and stripping are going down, as well as the amount of laser techniques and the new techniques that are using the thermal treatment. So far, so good. We are already more than 20 years after the first treatment. Me thinking about that, we have to thinking about that the patient that we do the first laser start coming back with recurrence. And the recurrence is a big trouble regarding about it will be surgical, it will be trauma, it will be switch of material, it will be hypoxia, or will be a thrombosis, will be inflammation. This is something that we usually thinking about when we are doing that. And we have the patient coming back. Yesterday, I did a case that the patient came back after 23 years that I did the saphenous vein. It was not an ablation, but a surgical case, but the patient still complained regarding about the problems. Look, if you saw it, this is somebody else who said because of the type of the surgical stripping. Somebody will say that it's because of new angiogenic tremor. But the problem is that you have the patient outside the office having this kind of trouble. One big vein that is coming, jumping over, giving a very big trouble, complaining of hasty pain and all the stuff that you usually have in these kind of patients. Why I choose porcupine? Because it's, as always, an ambulatory treatment. We are new materials, we have new fibers, it's local in office, less complication, and a fast post-operative. The requirement, as always, as ultrasound, use guide wire. You have to have very good guide wires. Terumo hydrophilic. Yesterday, I have one new guide wire that I saw. It's amazing, that lower broad. This is stuff, is new stuff. The radial fibers, the cadmium fiber that we were talking about, and we will work with that very nice. The patient didn't complain of any pain after the treatment. The local anesthesia has to be a good one, and the application of the specific link. It's not like 20 years ago when we fired the laser with a lot of energy, we burn everything. Right now, we just to give enough energy just to solve the patient, you give some power to the endothelial layer to get close. Well, the other kind that you have to remember is that you have to get a precision marking and working very fast, trying to fix everything. But there is no big difference between any kind of fiber, single ring laser fiber, double ring, infinite fiber, biofiber, the kind of fiber, all of them will give it to you a very good result. The energy, this is something that has to be changed. We have to do the average of the energy that you require is like a 40 joules, 60 joules. It means that will be between 2 to 6 watts to just close the vein and give enough stuff to, because this is a new, it's not the saphenous vein, it's just a collateral vein that reappear over there. As you can see, the tumescent has to be with a pump. You have to be master. I saw a master so many times already, giving a very good anesthesia. The patient after the treatment didn't complain of anything and is really very happy. Look, we have in the middle the fiber and it's getting surrounded by the fluid. This is the easy way to do the treatment and it will be very nice. I would like just also to present a 47-year-old, 85 years ago. This lady complained of this big vein, and you can see in the sonogram that there is a recurrence vein with a perforator in the Hunter channel. Look at the vein, it's going, and then you suddenly saw where is coming the refluxing vein. Was in the mid-tide. I decided to do a porcupine treatment, and after the treatment, we saw the left screen that you see over here, you can see that everything is closed and you will not see anything after the treatment. That was done under local anesthesia. Those are the areas that I fired the laser with a 4 or 5 entrance with a 16 gauge avocat. And the result was very nice. The vein was disappearing after, and the patient was very happy. Also, the reason of that kind of treatment is because you can do it in the office. The discomfort is just a little bit difficult because you have to give a little bit of local anesthesia before you start doing. As you see over there, the avocat has blood coming out, and this is something that telling you that you are already in. Besides that, you can help yourself with the ultrasound. Helping yourself with the ultrasound will give it to you the enough guidance to make sure that you are already in. This is another lady who I did like 7 years ago, and also with the anterior saphenous vein failing. You can see at the right side how I am putting in the catheter. Then in the other picture, that you can see how I fired the laser. Sometimes I fire the laser just with a needle. It's a short segment. You don't need to have like an introducer or something else. This is the area where I fired. I shut down the problem. The patient was happy, and this is before and after picture. They start working together regarding about numbers, regarding about porcupine, and we have to thinking about what will be the future of varicose vein treatment. We are talking too much, we are moving too much forward, and this is the idea. The final idea has to be, the way has to be teaching, and we have to keep supporting that kind of meeting that will be given to us in the future, real good outcome for our future patients. This is everything. Thank you very much. I hope we see each other in Venice. Will be a great meeting together. Thank you, Luca. Thank you, everybody else. I'm ready to take questions. Thank you.
Thank you so much, Prof. You really did a fantastic presentation. I enjoyed a lot Star Wars because I'm a big fan at the end of your presentation. So thank you so much also for that. Well, today we'll not have a lot of time for discussion, and every colleague that wants to make question can write in the chat, and then we will answer later to the question. And maybe the best way will be in Venice together and just talk about that, and maybe in the aperitif time also talk about Star Wars. Thank you so much. So we move to the next topic, and we now are talking in the last years about this topic, assessment and management of pelvic congestion syndrome. But we all learn from a pioneer in this segment, in this treatment. Of course, not just in that one, but everything I know, I learned at the beginning from Professor Mark Whiteley, and I'm really honored to have him today and in the scientific board for the next year. So, hello, Professor Whiteley. Microphone. Okay, we don't hear. Probably you should activate the microphone.
Lovely. Can you hear me now?
Yes, of course. Now we can hear you, Prof. It's a huge pleasure and honor to have you here and to hear from you something about pelvic congestion syndrome. So my question is, what are the reasons why pelvic congestion syndrome is an underestimated issue still today?
Thank you very much. I hope you can see my slides there. Can you?
Yeah.
Good. So I thought that was a very interesting question, because there's so many different meetings that we go to at the moment where we concentrate on obstruction reflux, how what imaging we should use, quality of life, and how we should assess the patients. And we get confused also between those patients who are presenting with symptoms and those who have leg varicosities, and of course more recently males with pelvic congestion syndrome. So I thought it was a very interesting question you posed. What is the reason why it's so underestimated? So what do we mean by pelvic congestion? Well, basically, when we're talking to patients and to non-vein specialists, we should just really call it varicose veins in the pelvis, because I think that really explains it. And of course, nowadays we use pelvic venous disorders, but if we just say to patients, there's varicose veins in the pelvis, it really helps them picture that there's a problem, because they already know what varicose veins are, and it gives them an idea of what we're looking at. And of course, like everything in medicine, we look at signs and symptoms. The difficulty with signs are, and this is a sort of collection of signs. On the left side here, we have a lady with classic leg varicose veins from the pelvis, and those next to that, the ones around the buttock can come from the perineum. And when I was a junior doctor, I was told, oh, lots of ladies have those, just pull them out. And when midwives get asked about these after pregnancy, especially if they're related to vulval varicose veins, they get told, don't worry, they'll disappear once you've settled down after the first few months. In the middle there, we can see at the top a man with varicose veins coming from the pelvis. We can see a patient underneath that who's clearly got a iliac obstruction and has got the usual collaterals going across the pubis. And of course, in the top right, we've got a male varicocele, and in the bottom, we've got both males and females, and how the hemorrhoids are related to internal varicose veins, and basically internal iliac vein reflux going down, usually pudendal, into this area. And there's more and more interest in these sort of areas. The trouble is, and when you say, why do we estimate it? It's because most of these patients will end up in the wrong place. They'll end up with venous or vascular surgeons who aren't interested in the pelvic veins. They'll end up with urologists. They'll end up with gynecologists, and they'll end up with colorectal surgeons, where all of this points towards patients that probably have pelvic congestion syndrome. They might just have one isolated vein, but they've probably got pelvic congestion in addition, or pelvic venous disorders, if you wish. So when we talk about patients who don't have those signs are obvious, and that helps us. But of course, most patients, especially the females, there's nothing to see on the surface. And if there's nothing to see on the surface, then we've got more of a problem, because we have to listen to our patients. And the problem is then the chronic pelvic pain and all the other sorts of things, irritable bowel, the cystitis, which they could never grow any bacteria from, and now in men, prostatitis. So the difficulty is all these patients are going to specialists who don't actually understand pelvic congestion or pelvic venous disorders, and don't even look for it. So if we look at the largest group that we're used to, and that's of course women, they usually go to gynecologists. And in England, as we published before, the Royal College of Obstetrics and Gynecology, their guidelines on pelvic pain doesn't actually mention veins at all. They've got 7 different areas that they say could be related, and endometriosis, of course, is always put at the top, but they've got psychological, they've got adhesions, got tumors and everything, but they don't mention veins at all. And that's the governing body in the UK for gynecology, and this is worldwide. There are two graphs underneath that, which we've just published on the College of Pathology preprint site. So you can see that if you wish to. We've submitted it as well. Hopefully it'll be a peer review afterwards. And what we looked at, we said, right, if gynecologists are interested, we should see an increasing number of research papers and reviews coming up in gynecology and obstetric and gynecology journals. But we don't find that. What we find on the left here is that of all the papers written in the last 12 years on pelvic congestion and pelvic venous disorders, only 11% are in obstetric and gynecological journals. The majority are actually in vascular, angiology or venous journals, and just behind that, radiology journals. And of course, the vascular angiology and venous are those of us who are diagnosing it and researching it, and the radiologists are those who are treating it. But the patients are going to the wrong doctors, because the ones they're going to, the obstetricians and gynecologists, aren't the ones doing or reading the research. So the second graph on the right here is that changing? And the grey at the top, the lighter grey, shows the total numbers of the publications that have been, and the dark grey underneath shows the number that have been in the obstetric and gynecology journals. And as you can see, it's not changing. The proportions, it's not as if the gynecologists are even getting interested in this area. When we then look at those patients who actually do turn up to vascular surgeons, because certainly in the UK there's very few of us venous surgeons, so the vascular surgeons, if they've read the internet, is where they might look for help. And there was this article that was published by Bruce Campbell, Professor Bruce Campbell, previously from NICE, and he put over 300 questionnaires, I think it was 382, I think it was, out to the members of the Vascular Surgical Society. Only 104 people bothered to return it. Only 100 said they treated veins or varicose veins at all, 18 of which wouldn't even investigate pelvic vein reflux. They thought either they had no reason to, they didn't believe in pelvic veins, or they thought that pelvic veins probably existed, but they weren't going to get involved in them. And only 5% who were treating more than, I should say 10 per year, sorry, not 5% per year. So there's a disinterest, even if the patients are reading that venous surgeons, vascular surgeons are interested in the area, there's a disinterest if they choose the wrong vascular surgeon. In our own publication that's just gone into the Vascular and Endovascular Surgery journal, what we found is that the patients who are most satisfied with their chronic pelvic pain relief took over 9 years to get a diagnosis. And most of those patients had actually gone through all of the gynecology route, they'd gone through all the other pain lots, the psychologists, and eventually had found something, usually on the internet or by a book, and actually had self-referred. And this has been replicated in several other studies, saying it can be up to 12 years before women who even find a diagnosis get one and treatment. So in summary, pelvic congestion syndrome or pelvic venous disorders is very common. It often presents as other isolated conditions, which ends up with patients going to doctors who only treat that isolated condition. It's often associated with multiple signs and symptoms. So patients might have hip pain, low back pain, deep dyspareunia, and might confuse doctors who aren't au fait with this condition. Most patients present, as I said before, to the wrong speciality and or to disinterested doctors. And this answers the question really that was posed, is why is it so underestimated? It's because it's not being recognized either by patients nor by doctors. So the plan is, in my session in Venice, Veins in Venice, we're going to discuss this. There's some new imaging and some new ways forward, and particularly we're going to be looking also at male pelvic congestion syndrome and trying to get some answers to these questions and seeing how we might be able to empower patients and get more doctors interested in this area. Hope to see you all in Venice.
Thank you so much, Prof. As usual, it was what a presentation. It's my sentence. A fantastic answer. I'm so happy to have you on board as a member of the scientific board. And also, I'm really honored to be part of the College of Phlebology. And also, I invite all the colleagues to join this fantastic group. You can learn really something important, and you can teach from the best, such as Prof. So thank you so much, and we move now to next topic, session number 7. So please, director. Okay, thank you. We have the slide. So we should investigate properly. We should do a correct assessment of the patient, and then we should move to treatment. Not just pelvic congestion syndrome, but also pelvic venous disorder, and also think about the pelvic leaking point treatment. But to delve in deep about this topic, I have another great name, and also a new friend of mine, I can say. I hope it's the same for him, Professor Ruben Rodriguez Carvajal.
Hello. Will you hear me?
Yeah, of course.
Well, hello, Luca. Hello, everybody. It's really a pleasure for me to be here with all of you And I have to say, Luca, yes, please, could you read these previous slides? It's going to be nice because I have not my own slides, so I will talk about pelvic disorders over these slides. As I was saying, it's a pleasure to be here, and yes, Luca, it's my pleasure to be in contact with you, with all your team, because I really enjoy how do you plan this wonderful international congress, focused in a modern way and focused on discussion and in a friendly forum to talk and to ask and to answer, and how Professor Kanata says, to teach and to learn from each other. Okay, so it was a really pleasure for me to receive this, to manage and to be the president of this session, treatment about pelvic congestion syndrome and pelvic venous disease. At least because, as Professor Wadi says, we have to find the way to overdiagnose, not overdiagnose, but to diagnose these diseases. And regarding treatment, we have to find even the way to normalize the treatments and to find better evidence to see how it is working and how it is not. And for this, we will plan a really big and really nice session that I invite you to come to Venice to share with us this wonderful session. That will be plenty of international colleagues that will talk about specifically the treatments of pelvic venous disease. As we know that we are getting progress in these diseases, starting with the normalization proposed by Meissner in 2021. We are talking now about pelvic venous disorders, and we are trying to find the way to define it, even to classify it with the SBP classification better than we were doing till now. And the same we have to do with treatment. So the question that you made to me, Luca, regarding if we have appropriate materials for these treatments, well, I have to say that yes and no, because we have to define first what we want to treat and what tools we will use to treat it. So regarding the pathology, especially the vein-related chronic pain in the pelvic disease, I have to say that we don't have still designed appropriated materials specifically designed for vein treatment embolization. So what we are doing, we are using materials from arterial embolization for previous diseases and for previous embolization process from the arterial field. It is true that I think that they are working pretty fine, but as I said, we have a big heterogeneity of treatments applied, and even the evidence that we have in the big series, in the big registries, are mixing different kind of treatments, mixing mechanical occlusion with colds, with sclerotherapy, even with plaques, or even with glue. That it's what in general we are using now for pelvic vein embolization. So for that, we'll have the chance to present to all of you our last work, our last 10 years work. They're going to be in primacy, first presented in Venice 2025. So we will present our series of more than 250 cases embolized only with one method, only with mechanical occlusion, with detachable fevered coils. And we will discuss with our colleagues another ways to treat it with the sandwich techniques, with glue for the pelvic embolization. So we can discuss the pros and cons, the benefits and the risks of each treatments. And I think that we can take great ideas and great conclusions from that discussion. Regarding the only big entity that we have to treat regarding pelvic venous disorders, that, as all of you know, are compressive syndromes. For this question, I have to say yes. For these diseases, we have special and dedicated vein stents that have been designed from the last 10 years with big multi-centers and prospective registries, supporting especially very good data of patency and of symptom release regarding especially non-thrombotic compression syndrome. So I think that we will discuss especially what is concerned to the left renal vein compression syndrome, because I think that probably it's the field in compression syndrome that we are still lacking for a specific endovascular solution. And we'll have the chance to talk with Dr. Morata, that it's a big expert in surgical repair of a nutcracker syndrome. So we can see and put in both sides surgery against endovascular treatment of nutcracker syndrome, actually. And that's going to be more or less the summary of the session. I think that it's going to be a really nice session, so I will invite all of you to come to Venice.
We have now lost the signal, I think. I hope the other colleagues can hear from me. Let me say, I can't wait to attend to this session. I think it will be a great session. And I already have a lot of questions to Ruben, that has a great experience on this treatment. And so please come. Let's move to the next session, session number 8. This session is dedicated to aesthetic phlebology, and we will touch a lot of key points. I summarize some of them here. It's really important to remember and to try to manage expectation and avoid and manage complications that we all have for this type of treatment. But also we will discuss in the specific regarding the technical note of the most done procedure for this treatment. And last but not least, a question that we always have: elastic compression, yes or not after the treatment? But to talk about this topic, I have the pleasure to invite Professor Sandeep Rai-Pandey to speak about how to avoid complications and to introduce this topic. Thank you so much, Prof.
Good evening, everyone. Thank you, Professor Luca, for this honor. So maybe I'll be speaking in more detail during the BIB physically. So now I have just summarized the points, how to avoid complication in sclerotherapy. And today there was a big flood in Nepal, so many people have also died. And just now I got the power. Before in the day, all the electricity was cut off. So I'm lucky to get in touch with BIB now. So just we'll be discussing the basic of sclerotherapy. If it is done in safe hands, it is always safe, but still even the expert can lead to complications. And so before doing, we should always know the adequate venous anatomy, ultrasound and hemodynamics of the phlebology, so that we can avoid the complications. And I'll be explaining the more detail of the complication during the congress, like urticaria, intravascular hematoma, hyperpigmentation, telangiectasia, matting or necrosis, DVT or superficial vein thrombosis, and other complications. So complications can happen even to the most expert practitioners, so we should be take cautions. So to avoid the complication, I'll be explaining the 10 rules by Hamel and Dessons. How the operator have to be the training, and what should be the mixture of the foams, and how long should we be giving the foam as soon as it is prepared, and the angle of the needles, and all the details of the reflux zones where we are injecting first and later, and ultrasound guided, which is always more safe. And to avoid the complication, we should also do the regular follow-up. So these things I'll be explaining more detail during BIB in Venice. And the complication will be just that it can happen to even the most experienced practitioner, and they should know how to manage them, and always think that prevention is better than the intervention. So aesthetic phlebology, we should be very cautious to avoid the complications. Thank you.
Thank you so much, Prof, for your presentation and to be in the time. So we can now move to last presentation. Let me say that the sessions, we presented all the session except for one, session number 9, that will be abstract session. Of course, we will discuss about that directly in Venice, but that's give me the chance to remember everyone that in this moment is not in the panel, is not in the faculty, that if you want, you can just go on our website, www.veininvenice.com, and fill the abstract form and send us. Best communication will be selected from the scientific board, and we'll have the chance to speak in the plenary session at the next Vein in Venice, and of course be part of the faculty. So please don't lose this opportunity. We are really open and to everyone, and to welcome you in Italy and in Venice. But I want to move to the last but not least, let me say, and I really think about that topic of today. That is a topic of a workshop that I really wanted for this year. It's something that I really take care about, and no better way to explain and talk about that have today Pierluigi Antignani, that is now I can say a friend, but is probably one of the most opinion leader in how to write a scientific paper. He's a editorial board of several journals, and a great expert. So thank you so much for joining us to be part of the faculty, Pierluigi.
Thank you, Luca, and congratulations for excellent scientific program. I think the Congress in Venice next year will be very, very stimulating.
Thank you.
Well, during the workshop, we will try to explain what is the best point to write a good scientific paper. The first point is to define what is the message of your paper. Probably is better to write a little sentences in which you report what is the aim of this paper. Another point, very important, is to organize the different part of the paper with the material methods, results, conclusion. It is very important, don't write the abstract and the introduction before, but at this point, these two parts, you have to write after you have prepared the paper, because in this way you can put in the abstract the big important message, and the introduction explain what is your work, completely your work. The other point, and I conclude, you have defined before the writing the paper with the journal in which you wish to send the paper, because there is a different rules in different journals, and you have to follow, of course, these rules. For example, some journal now wish to complete the paper with some statistical page in which you report the main point, and you have a list of answer to of a question to answer before sending the paper. But all of this we discuss, of course, during the workshop. And again, I thank you for the invitation, for this commitment.
Thank you so much, and I invite all the colleagues to join this fantastic workshop. I think that most of us have something to say and to write, but sometimes we don't know how to write it in the right way, how to choose the right statistical method to
yes, of course.
Your findings, and but it's something that we can learn and of course train. So thank you so much, and thank you also for the patronage, but I will tell after a while about the patronage that we will have the next Vein in Venice. So thank you so much, Pierluigi. And
it is a pleasure. It's a pleasure for me.
thank you so much. And we have now Ruben that is connected again, just to say just say hi to everyone and then invite them again to the next Venue in Venice. Ruben, if you want to conclude.
Yeah, thank you, Luca. Sorry, my connection fell down unexpectedly, and I just want to say thank you again, Luca, and thank you to everybody who is connected today. And I hope sincerely to see you all in Venice 2025. I think it's going to be a great meeting. We will enjoy for outstanding presentations and speakers. So be really welcome. We wait for you there to discuss and to enjoy doing science. So thank you very much, and see you next.
Thank you so much, Ruben. It was a duty to let you conclude your speech, and really, I can't wait to attend to your session because I think it's a great topic. It's really interesting, and I hope also industry could come and listen what is now what we need now to help better our passion in this treatment area and to improve also the results. So thank you again. And now
You're welcome.
Thank you, Ruben. I asked to the director to move to the last couple of slides, and then you will be free to enjoy the Saturday. So next slide is, as I spoiled a few seconds ago, it's a thank to the main society and patronage that we received. Some technical problems as usual, but in Venice will be all really smooth and flow because there is no connections to limitate our speed. And well, you can also okay, you probably see now my screen. I do by myself. Do you guys see? I hope my screen. Okay, so before to thank, I told you that I would tell you how easy it is to attend. So please go and visit www.veininvenice.com, and you can find in the homepage the sign up button. You just go there and you can fill and register in a few seconds with really in a fast way. And you can decide for this year how to attend. We will give the chance to attend in person and until the end of December, we'll give the early bird registration with the discount. And but also for the next year, if you want, you can attend with the online participation, in which I have to tell you, we will be able to follow only the plenary sessions and not the workshops. So better to come and get a good coffee with us. And so now the special thank. The special thanks to the patronage, of course, the College of Phlebology. I not only am a member, I was honored by the College of Phlebology to be and to achieve an honorary position of associate professor. So thank you so much, and I will do my best to also in teaching. And thank you also to Vein and Lymphatic University. Still, I'm a member of this community. It's fantastic. They share knowledge and also life cases and everything we need to improve our daily practice. Fondazione Ville Salus, that is the foundation of my hospital in Venice. So thank you for the everyday support in the clinical practice. But also thank you to the Himalayan International Vascular Summit. We also support them and their symposium. Also to thank to Pierluigi Antignani and in the specific at the International Union of Angiology for their patronage. Really an honor for us. It's a huge society, and so we were pleased to receive their patronage. Last but not least, my association, Cura Vene Roma. And anyway, for more information also about that, you can visit our website, veninvenice.com. And in the end, in conclusion of this wonderful meeting, except for technical problems, but I think it's live, and the show sometimes have a problem, but we moved without problems. So in the next episode, we will talk about the workshops, and we will discover about that, about the speakers, and what you can find. Also, we will introduce you additional faculty members that today we had no time to introduce, and so please stay connected, stay tuned. And finally, I will show you a little bit more about the location, and so you will be ready and prepared to come and visit our symposium. Thank you, everybody. Thank you also to the team of Vein in Venice that every day help me in the difficult, really difficult work of get everything ready and to reach people from other countries, other time zones. So it was not easy also for helping me with the Zoom. The next one will be better than this, and I can't wait to see you all in Venice. Thank you so much, and goodbye. Ciao.